So, good afternoon, everybody. Thank you for joining us for our Living with Kidney Disease and Transplantation. I am Rachel DePaul. I'm the Senior Director of Programs at the National Kidney Foundation of Illinois, and I'm so happy to welcome you all this afternoon. Um, as a reminder, the mission of the National Kidney Foundation of Illinois is to improve the health and well-being of people at risk for or affected by kidney disease through prevention, education, and empowerment. I'd also really like to thank our sponsors for today because they really make everything that we do possible. DaVita Kidney Care, Fresenius Kidney Care, Gift of Hope Organ and Tissue Donor Network, Northwestern University Medicine, and UI Health. Throughout today, if you have any questions, please use the chat button at the bottom of your screen to type a question, and we'll be answering your questions at the end. Also wanted to share that we have some really great sessions lined up over the next about 2.5 weeks. So we have these mini pre-recorded sessions that are about 3 to 5 minutes long. We'll be emailing the links to you, but they'll also be available on our Facebook. We also have a great series of really exciting lectures, panel discussions, and even a networking night. And just a reminder that every live lecture and panel you attend, you'll be entered or given another raffle ticket or raffle entry for our raffle. I also ask that we will be sending you a link to a survey on Friday afternoons for the next 3 weeks. And we just ask if you could help us complete the survey and help us better plan our programs in the future. And lastly, we are looking for a new name. Living with Kidney Disease and Transplantation is a little bit of a mouthful, and so we're really looking for a new name that really highlights what we do in terms of education for this program. So if you could think of a great name, if you want to email your suggestions to me at rdepaw@nkfi.org anytime between November 1st and November 30th. We'll be announcing the winner in early 2021, and if your name suggestion is chosen, we'll be sending you a $100 Visa gift card. So at this time, I am really excited to introduce Dr. Divya Jain. Divya is a transplant nephrologist at Loyola, and she is also the chair of our programs committee. So Divya, I'll turn it over to you.
Thank you. All right, so can everyone hear me? I hope so. Rachel will let me know if you can't. So this is called Reading and Understanding Your Labs. My understanding is that this was actually requested by previous attendees of this program. So I wanted to get into that. It's a bit dry because it is just about labs, but hopefully the explanations will be helpful. Okay, oops. There we go. So objectives: to understand basic lab values that are monitored by your provider regarding kidney function.
Would you mind sharing your screen?
Oh, I'm sorry.
It's okay.
It's not shared. Give me just a second. Share screen. Now you can see it, yes?
Yes, now we can. Thank you.
Okay, thank you. Okay, so let me just make sure this is, there we go. Oops. Okay, to understand basic lab values that are monitored by your provider, I want you to be able to understand other labs that are monitored when you have chronic kidney disease and to understand the importance and the trend of trending labs. So first off, when you get labs drawn, you should know that we are just getting them drawn right at that time. So it's very static. It is not dynamic. And so that's why trends are so important. So one lab value does not make or break anyone. It's more about what is the overall trend. Usually I like to see at least 3 previous lab values for each value that I look at to kind of determine, is this actually where the person runs around? Could this lab be erroneous? Could a previous lab have been erroneous? You know, to find out where's really someone's baseline, especially when it comes to kidney function, you definitely want to try and figure out a baseline. Just like blood pressures are not static, they fluctuate every minute. Your lab values are also dynamic. So starting off, you have the CBC, which is known as your complete blood count. And so I wanted to highlight 3 of the lab results for the CBC. So the first one would be white blood cells. It's usually one of the first reported. I know at least for us, it's first reported on the CBC. And so white blood cells are sometimes called WBCs, and these are also known as leukocytes. And so why are white blood cells important? Well, especially in these days of COVID, they are the cells that protect your body from infection and foreign invaders. And so the normal range, it's pretty broad actually. So it's anywhere from 3,500 to 10,500 cells per microliter. And if it's too high, that's called leukocytosis. And if it's too low, it's called leukopenia. So leukocytosis would be anything above, let's say, 10,500, and leukopenia would be below 3,500. Now I'm saying around is the range and not definitely the range, because each lab has a differing normal range. They're usually all kind of around the same, but one might say 4,000 to 11,000, one might say 3,000 to 10,000. So that's why I said 3.5 to 10.5, but you should always be able to identify the normal range for each lab value. And when you're looking at a printout, your results will be on one side, and usually there's a normal range right next to it. And there might be either an H or an L, H for high or an L for low if your lab value is above or below it respectively, or there might not be anything written, but there might be arrows. So again, if there's an up arrow, it's signifying that it's high. And if it's a low arrow, it's signifying that it's below their range for normal. So white blood cells, when they are too high, we call that leukocytosis. And so that means that there's too many white blood cells. And what are possible causes of leukocytosis? So some of the first things that come to my mind when I think about someone who has leukocytosis, the first two would be inflammation or infection. And so I'm a transplant nephrologist, so I really try and hone in to make sure that someone's not infected. So I start asking them questions: fevers, chills, nausea, vomiting, diarrhea, things that might signify an infection, cold symptoms. Inflammation can also cause leukocytosis, because whenever you have an inflamed tissue, your white blood cells are there and they're attacking it to try and heal it. I didn't know if I just heard something, but hopefully that doesn't mean anything. Okay. I see 3 chats. Are there questions? Okay. Now, the other thing I wanted to know, or I wanted to let you know, as far as other things that might cause leukocytosis would be, such things as leukemia, which is a blood cancer. Now, if something is too low, if your white blood count is too low, that's called leukopenia. Penia, P-E-N-I-A, is at the end of a lot of words. And anytime you see that word penia, that means deficient or low. So in this case, leuko meaning white, and specifically referring to the white blood cells. So leuko, white blood cells, penia, are low. And so why do I care about that? Well, if your white blood cells are low, that could mean that you are possibly at a higher risk for infection. And so that's important to note, because we don't want you to get infected, and we need to make sure that your white blood cell counts aren't so low that you might not even mount a response if you do get infected. So an immune response that people mount when they are infected includes fevers, chills. Those are immune responses. Some patients, though, when they don't have enough white blood cells, they can't even mount that response. Other reasons for leukopenia include medications. So I happen to be a transplant nephrologist, and a lot of the medications I give to my transplant patients, they will deplete white blood cell counts, whether they be certain antibiotics, certain anti-rejection medications, chemotherapy agents. Those things can all deplete the white blood cells. So we have to be cognizant of what we're giving someone. Certain infections can also lead to this. So I know I said that infections usually cause a high white blood cell count, but then there's certain viruses such as cytomegalovirus or CMV, parvovirus, and even HIV that might lead to a lowering of someone's white blood cell count. Aplastic disease means that the body is not making enough cells. And then myelodysplastic disorders, which are a disruption in blood cell production. Okay, so the next lab that I wanted to discuss was hemoglobin. That's also found on the CBC, or complete blood count. So hemoglobin sometimes is also called or abbreviated HB or HGB. And so hemoglobin is specifically what it is. It's actually a protein component of red blood cells, and it's made from iron. And the job of hemoglobin is to carry oxygen to vital organs and tissues. So, normal range, at least at our institution, is 13 to 17.5 grams per deciliter. So, if it's too high, you have erythro, which is referring to the hemoglobin or red blood cells, cytosis. And if it's too low, you'll be anemic. So, what are some reasons that someone might have what we call erythrocytosis, or a hemoglobin that's too high? Well, it occurs in conditions in which your body feels like it's not having enough oxygen and that it needs to carry more oxygen to tissues. And if that's the case, it's going to increase the hemoglobin. So, smokers basically, when they smoke, you're not keeping yourself with enough oxygen. So, your hemoglobin ramps up so that it gets the oxygen to your vital tissues. People in high altitudes will have higher levels of hemoglobin. After transplant, some patients go from being anemic to actually having what we call a post-transplant erythrocytosis. I usually happen to see this in patients with polycystic kidney disease as their original disease that caused their kidney failure. And so in those patients, I really watch to make sure that they do not get that post-transplant erythrocytosis. If they do, we have to treat it. I usually treat erythrocytosis at least with an aspirin, and then there are other medications that can help bring the hemoglobin down. Another reason someone might have a high hemoglobin level is it's falsely high because of dehydration. And so if you're dehydrated, it looks like your hemoglobin's high, but really it's just that your volume status is not enough. You don't have enough like fluid or water in you. And if you drink a little bit more, then your hemoglobin levels will be more normal. On the opposite end, if your hemoglobin is too low, you're anemic. And so chronic kidney disease is one of the major reasons for anemia. Colon cancer is another reason for anemia. Any type of iron deficient condition. And then there's also a disease called thalassemia that some people might have. That's also a reason for anemia. Now, I mentioned that hemoglobin is made from iron. The reason I mentioned that is because our first line treatment for patients who are anemic, as far as evaluating them, we first check your iron stores. So we want to make sure that you have good iron stores in your body, that you're not depleted of iron. If you're depleted of iron, one of the first things to do, especially if you're over the age of 50, is to make sure that your colonoscopy is up to date. If it's not up to date, we repeat it. Or if we think that you might be having some bleeding, then we'll repeat the colonoscopy. That's one of the first causes to look for as far as iron deficiency. If it's determined that that's okay and there's nothing going on, then we also put patients on iron supplements. Some patients will take iron supplements by pills, and other patients might need it by IV because their stores are so depleted. Once your iron stores are replete, then we'll move on to another agent, which would be erythropoietin. And so erythropoietin agents are like Aranesp, which is known as darbepoetin, or Epogen, or Procrit. A lot of people know those terms from dialysis, and usually you've received those in dialysis. So what is erythropoietin? Well, it's a hormone that's primarily produced by the kidney, which aids in the production of red blood cells. In chronic kidney disease, some of the patients, they receive these erythropoietin stimulating agents to help treat their anemia. Again, you must have adequate iron stores before we move to that step. So the last thing I wanted to look at in the complete blood count are your platelets. So why are platelets important? Well, platelets are actually cell fragments. So they're not cells, but little fragments of cells, and they assist in blood clotting. In kidney disease, especially chronic kidney disease, advanced kidney disease, when patients are on dialysis, we often say that patients suffer from dysfunctional platelets, meaning their platelets don't always clot as well as they should if someone's kidney disease is so advanced and it hasn't been treated. Usually, patients on dialysis won't have these issues. Normal range for platelets would be about 150 to 400,000 platelets per microliter. If it's too high, it's a condition called thrombocytosis. And sometimes we see this thrombocytosis in conditions like polycythemia vera, which is a little bit similar to when you have high hemoglobin levels. But not only will you have high hemoglobin, you might also have these high platelet levels. I'll see this with other blood and bone marrow cancers and also a certain type of leukemia called CML. If they're too low, which is thrombocytopenia, there's reasons for that. So sometimes patients, when they're in the hospital, they might get an agent called heparin to prevent blood clots from forming. And when they get that, some patients will actually have a reaction called heparin-induced thrombocytopenia. So their platelets fall because of the heparin. Another reason that someone might have low platelets is due to sepsis or other overwhelming infections. There's also idiopathic conditions, meaning conditions that just arise. There's no cause for them, they just happen, called ITP or idiopathic thrombocytopenic purpura. And then another syndrome known as hemolytic uremic actually refers to the kidneys in this case, syndrome. And so when you're hemolytic uremic syndrome, you have low platelets, low hemoglobin, and kidney dysfunction. So moving on from the CBC, where I wanted to cover what I happen to think were the three most important labs to know on your CBC, I wanted to move on to the chemistry panel. And so the chemistry panel is the one that patients usually ask about when they're like, hey, what's my kidney function? What's this showing? So when you look at a chemistry panel, it's a blood test and it looks at your electrolytes, your kidney function, your sugar levels, and possibly your liver function as well. So I'm going into the electrolytes first. And so we have sodium. Sodium is an electrolyte that helps with cell functions and mostly it helps to regulate the water in your body. And so it's important because we need to know what your fluid status is at all times when we talk about patients with kidney disease. Normal range is usually from 135 to 145 milliequivalents, which is MEQ per liter. If you have a condition where your sodium is too high in your blood, that's known as hypernatremia. And if it's too low, it's called hyponatremia. And so common reasons for hypernatremia would be dehydration. So again, you've lost more water than what's in your body, but the sodium has stayed in, and that will lead to a state of hypernatremia. Additionally, some medications, so medications that are known as Lasix, Bumex, torsemide, furosemide, bumetanide, these are a class of medications called loop diuretics, and those medications could cause you to have a little bit higher sodium level. Diarrhea, because diarrhea leads to dehydration, can lead to sodium levels that are higher. And then, of course, kidney dysfunction. Too low, so always kidney dysfunction can give you low sodium, especially when you have advanced kidney disease and your kidney can't really regulate your electrolytes really well. And so patients usually in between dialysis sessions, because they're drinking fluid, when they start their next dialysis, they'll have a little bit of hyponatremia, or their sodiums will be too low compared to when they ended their last dialysis session. So drinking too much water is going to lead to hyponatremia. Some medications, so a different class of diuretic or water pill, such as thiazide diuretics. So these ones are hydrochlorothiazide. You might also know it as HCTZ, chlorthalidone, metolazone. Those medications might cause low sodium levels. Heart failure, congestive heart failure is a big reason for low sodium levels, where patients, if they are in exacerbation of their heart failure, meaning it's worsened, they'll have a lot of swelling and excess fluid on them, and their sodium levels will actually be quite low. Liver failure is also a very common cause of low sodium. I mentioned kidney disease, and then also thyroid failure. Thyroid disease can lead to low sodium levels. The second electrolyte I wanted to talk about was potassium. So potassium is very important with cell functions, especially with the muscles. And one of your most important muscles in your body is your heart. And so this is why we care about potassium so much, because when potassium levels fluctuate, especially if they go too high, that could be potentially fatal, and patients can die from high potassium. So a normal range in potassium is 3.3 to 5.1 at my institution. If it's too high, then a patient is hyperkalemic. If it's too low, then a patient is hypokalemic. So with hyperkalemia, causes for it might be someone who has kidney disease and they're not following their low potassium diet. And so if someone has kidney disease and they're eating like lots of oranges, orange juice, citrus fruits, instant oatmeals, peaches, um, tomatoes, bananas, those are all part of a high potassium diet, and that can increase your potassium and potentially lead to fatal hyperkalemia. Rhabdomyolysis. So this is a condition that actually can cause kidney failure in the emergent setting. And what rhabdomyolysis is, it's when your muscles have intense breakdown. And so with that, the potassium is actually stored inside of your cells. And what happens is your cells lyse or explode. And when they explode, the potassium goes into your blood, and then it's known as high potassium. Same thing if someone has um, a blood cancer and they have a lot of burden of that cancer or tumor. And when some patients get chemotherapy for this, essentially what happens is these cells explode from the tumor, from the actual cancer. And whenever that explodes, it releases potassium into the blood, and that's known as tumor lysis syndrome. And then medications. So we talked about water pills. Water pills can increase sodium. Water pills can decrease sodium. Water pills can cause high potassium levels. And then later on, I'll talk about water pills also decreasing potassium levels. So certain diuretics or water pills that might increase your potassium include spironolactone, and other medications that are not water pills. So ACE inhibitors are a class of medications, and some of those include lisinopril, enalapril, Basotec. These are medications that could increase your potassium, and then their sister medication are known as ARBs, or angiotensin receptor blockers, and the names of those medications would be like Diovan, valsartan, losartan, Cozar. Those medications can also increase your potassium. And again, I cannot stress this enough, but high potassium can be fatal, which is why if someone calls you to ask you how are you feeling, if they know that you have a high potassium level, they're also probably going to treat you for that high potassium. When I treat a patient for high potassium, I also then repeat the lab within the next couple of days to make sure that it's come down. When potassium is too low, this is known as hypokalemia. And so causes of hypokalemia, diarrhea. So not only will your sodium possibly go up with diarrhea if you lose a lot of fluid, but if you lose your electrolytes, then you might become hypokalemic. Thyroid disease can also lead to low potassium, just like some thyroid disease can lead to low sodium. Medications such as your diuretics, the water pills, so not spironolactone, but your thiazides, which I talked about, hydrochlorothiazide, chlorthalidone, metolazone, but also the loop diuretics that I mentioned earlier. That was your Lasix, your Bumex, torsemide, furosemide, bumetanide. Those water pills can lower potassium. And then if someone has low magnesium levels, so potassium needs magnesium levels to be adequate before the potassium level can be adequate in your blood. So if you have low magnesium levels in your blood, then your potassium level will also be low. So the next one is carbon dioxide. And so carbon dioxide, or CO2, helps to tell us how acidic your blood is. And the reason nephrologists, kidney doctors, care so much about this lab value is because it is actually shown that a patient with advanced kidney disease, especially if, in stage 4 kidney disease, so we're not yet on dialysis, but you're getting closer to it. It's been shown that if you treat someone's carbon dioxide level, if it's too low, and you give them a supplement, that can actually help slow down the progression of kidney disease. So we pay attention to that CO2 level, because if we can slow down your progression of kidney disease and going on to dialysis, that's what we're always going to go for. So the normal range in our institution is 23 to 29 milliequivalents per liter, or MEQs per liter. And if your CO2 level is too high, that tells us that you have something called a metabolic alkalosis. If it's too low, then your blood is acidic, and we call that metabolic acidosis. So if it's too high, some potential causes, again, dehydration, excess antacid use. So if you're taking a lot of antacids, that might have some carbon dioxide containing or in them, that can also increase your levels. And then medications that might dehydrate you. So again, those diuretics, the water pills. If you get too dehydrated, we're going to see that CO2 level go up. Metabolic acidosis is something we see in advanced chronic kidney disease. So again, that's why we're always trying to treat that number to make sure that we're slowing down the progression of renal disease. Severe infections. So a lot of my hospitalized patients, when they are infected, they'll have these low CO2 levels in their blood. And then intense exercise. So if you are exercising and then you get those sore muscles, especially the next day, where it's not even a cramp, but it's something really sore, that's usually due to a buildup of something known as lactic acid. And so that causes this metabolic acidosis in your body. Calcium. So calcium is a mineral. We store calcium in our bones. Your kidney actually helps to regulate calcium. And so the normal range of calcium is between 8.9 to 10.3 milligrams per deciliter. And we look at calcium because of the fact that it is so important for you to have strong and healthy bones. And if you have kidney disease, you might be depleting your bones from that calcium. And so that's why we're always monitoring that. Some patients have calcium that's too high, and that's known as hypercalcemia. Hypercalcemia is a condition that we worry about because a lot of times it makes patients feel crummy. So people can have headaches from high calcium levels, they can have abdominal pain, fatigue, those types of things will be symptoms of hypercalcemia. From a kidney transplant perspective, I always get concerned about hypercalcemia because what it does to blood vessels. So when you have high calcium levels, the blood vessels might be going from this, and they might actually be constricting due to those high calcium levels. And when they constrict, you're decreasing the blood flow to the kidney. And so for transplant, that's important because I don't want to decrease blood flow to that kidney transplant. So reasons someone might have hypercalcemia, well, one of them would be a condition known as hyperparathyroidism, and we'll go into what the parathyroid is in just a minute. Medications. So your thiazide diuretics, that hydrochlorothiazide, HCTZ, metolazone, chlorthalidone, those ones increase calcium in your blood. Lung diseases such as sarcoidosis, which also can lead to kidney failure, is a reason for high calcium. And then some cancers also present with high calcium levels, such as certain types of lung cancers and breast cancers. If the calcium is too low, that's known as too low, calcemia. And so reasons for that. Low vitamin D levels. We're always looking at patients' vitamin D levels. I think there's been a lot about it in the news recently because studies have shown that adequate vitamin D levels might be helpful as far as warding off COVID or lessening the severity of COVID. So low vitamin D levels might be a reason for low calcium. Chronic kidney disease, high phosphorus levels, we might see that associated with low calcium levels. And then medications such as Lasix, Bumex, furosemide, bumetanide, those water pills will cause lower calcium levels. And actually blood transfusions. So patients who might have lost a lot of blood, if you've had a bleeding incident and you need to get transfused a few units all at once, that massive blood transfusion, multiple units of blood, can decrease your calcium levels due to a preservative that is in the blood. So now that brings me to phosphorus. So another mineral that we look at for bone health in kidney disease. And so it's known as PHOS or PO4. And so there's a normal range of 2.5 to 4.7. If it's too high, we call it hyperphosphatemia. And so usually you see that with patients who are not controlling the phosphorus in their diet. So if you're consuming a lot of cheese or a lot of dairy, a lot of dark sodas, nuts, or just a lot of processed foods, they are going to be high phos containing foods. And if you have chronic kidney disease, your kidney is not efficient at getting rid of that excess phosphorus. Hypophosphatemia, I happen to see a lot after transplant. So patients go from high phosphorus levels and needing phosphorus binders to treat their high phosphorus levels, and they get a transplant, and then they drop their phosphorus levels. And so they're off of the phosphorus binders. And now I'm putting my patients on phosphorus supplements. So again, you could have hyperparathyroidism, a different type that cause hypophosphatemia, and then also low vitamin D levels. So, parathyroid hormone. I have a little picture here, and in the picture, this is actually your thyroid gland, which sometimes you can feel it right here in your neck. And at the back of the thyroid, so all the way in the back here, you have what's known as your parathyroid glands. And so they're just these little dots, essentially, these little yellow circle glands, and there's 4 of them. And those secrete the hormone, parathyroid hormone. And so why do we have them? Well, when the calcium level in your body is too low, and let's say you don't have any kidney disease. So when the calcium level in your body is too low, this sends a signal over to your brain, which then tells your parathyroid gland, hey, we need to increase the calcium in the body. And so the parathyroid hormone gets secreted from the parathyroid gland. It then helps to regulate the calcium in the body. So the hormone will let the bones know to try and release the calcium. It also lets your kidneys know to try and reabsorb that calcium, and your gut. So we're trying to increase the calcium levels in the blood. Again, calcium is very important too when it comes to cell function and muscle function. And so some patients, though, with chronic kidney disease or advanced kidney disease, they have low calcium levels persistently. And so that keeps that feedback of your parathyroid gland keeps trying to secrete hormone to no avail, meaning the calcium levels are not going up despite the parathyroid hormone or parathyroid gland secreting so much parathyroid hormone. Some patients, though, after transplant have high calcium levels, and now their parathyroid hormone has not shut off. And that can be an issue because then you're getting a response and calcium levels are going up and up and up. And really, it should have shut off once it saw that once it saw that the calcium levels were high. Sometimes, though, patients might have high parathyroid hormone levels because of that overactive gland. And when we do that, what we do is we treat it. And you can surgically remove the parathyroid gland from the thyroid. And usually you keep one or two of the glands just so that a patient doesn't have to be on calcium supplements for the rest of their life, and so that we don't replace one problem with another. So vitamin D levels, your 25 hydroxy vitamin D or 25 OH vitamin D. So it keeps your bones, teeth, and muscles healthy, might have some anti-inflammatory properties. I mentioned it might be helpful in COVID as well. Normal range is usually 30 to 50 nanograms per milliliter. If it's too high, you have vitamin D toxicity. If it's too low, you have deficiency. Too high can lead to high calcium and effects on your bones and tissue. And it's usually caused because patients have ingested too much of the vitamin. So they've just taken lots of supplements. And so maybe instead of taking the supplement once a week, they've now started taking that weekly supplement daily. That's going to give you toxicity. If it's too low, that's known as deficiency. And so it might be that you're not absorbing the vitamin D. So vitamin D is a fat-soluble vitamin. And so if you are having a lot of like oily diarrhea, you're not going to be absorbing your vitamin D. Also, if you're just not taking in enough. So if you're not taking supplements, or if you're not going into the sun very much, then your vitamin D levels might be low. Magnesium. So magnesium is also important. I mentioned earlier that your magnesium levels must be adequate in order to have adequate potassium levels. So your normal range is going to be anywhere from 1.8 to 2.5 milligrams per deciliter. If your magnesium's too high, it's called hypermagnesemia. If it's too low, it's called hypomagnesemia. Common causes of high magnesium levels would be laxatives, antacids, and hypothyroidism. So laxatives meaning like milk or magnesium citrate if someone's constipated, or antacids would be milk of magnesium. Those ones are going to lead to high magnesium levels. Too low, so in this case, the antacid that might lead to magnesium levels that are too low would be chronic use or long-term use of proton pump inhibitors. That is a class of antacids. So which ones are those? Those are antacids that end in like prazole, P-R-A-Z-O-L-E. So omeprazole or Prilosec is going to be a proton pump inhibitor, and that can lead to low magnesium levels. Diarrhea also can lead to low magnesium levels, and alcoholism. Now that brings me over to glucose and hemoglobin A1C. So your glucose level is going to be your blood sugar level. And if you are fasting and you're not a known diabetic and the level is 101 to 125, so anywhere above 100 but less than 126, that is a condition known as impaired fasting glucose. It's also sometimes called prediabetes. So that's something to be aware of, because if you have impaired fasting glucose, this is your time to act upon it. You know, to really try to decrease your sugar intake, making sure that you're exercising. If you need to lose weight, working on losing weight in order to not let that impaired fasting glucose develop into overt diabetes. Hemoglobin A1C, also known as glycated hemoglobin, is a level that we check, and it basically reflects the average of your 3-month level of blood sugars. Now, with it being average, there's a caveat to it. Some patients can have excellent A1Cs. And so their A1Cs look like this, and you're like, wow, they have such great control over their diabetes. But then I look at their actual blood sugar log, and they're having super highs and super lows, which are dangerous in each direction. So when you take that average, it looks great, and it'll give you a great blood sugar level average, which then equates to a great average on your A1C. But if you're having these labile blood sugars, that's an issue. So I don't look at just the A1C, I want to look at all of the numbers. And then an A1C of 5.7 to 6.4 without a known diagnosis of diabetes is going to indicate prediabetes. The American Diabetic Association kind of keeps decreasing that number and becoming much more strict about what they are referring to as diabetes. And so now an A1C of 5.6 or less is good, but 5.7 or above is either prediabetes, or if it's above 6.5, then you're a diabetic. It used to be that an A1C of 7 was what you would diagnose with, and then it was 6, and now they're saying 5.7. You need to start worrying again and about, the fact that you might be a pre-diabetic. And then before I go on to your analysis, the one lab that I wanted to go over that we did not go over yet would be your creatinine. So that's what's going to tell me about your kidney function, your creatinine. And so most patients are like, hey, what's my kidney function? So creatinine is a number that is then related to your GFR, or kidney function. And I always tell my patients creatinine scores or levels are like golf scores. The lower the creatinine, the better the kidney function. Same thing in golf. The lower the score, the better. So you want your creatinine to be low. Mostly, I usually, just to be easy about it, I will say I refer to a reference range of 1. Around 1 is where we want someone's creatinine to be, ideally. But I'm not necessarily upset or disappointed with someone if they have a creatinine of 1.5 and it's stable. So again, it's that importance of looking at a trend versus just looking at one number. Some patients after transplant, their best creatinine might be 1.5. They might not get down to a 1. And if you're 1.5 for 10 years and that's all you're at versus 1, and in 10 years you go all the way up to 2, even though it was a slow rise, I prefer the 1.5 steady the entire time than the 1 to 2 slow rise. A steady kidney function is better than a worsening kidney function. And so creatinine relates to GFR, or kidney function. And so GFR is actually calculated from your creatinine. And in this case, you want your GFR to be high. So high GFR means better function. If someone's GFR is reported at 60, that means if, let's say, you have person A over here and they have normal functioning kidneys, their GFR, let's say it's worth $1. If someone else's GFR is 60, I basically say that's saying like it's at 60% or around 60 cents compared to that dollar over there. And then that puts it into perspective. GFR needs to be interpreted closely because it can't always be interpreted if someone actually has normal kidney function. So if you actually have normal kidney function, we should not be looking at someone's GFR. There are misinterpretations for this because some of these equations or formulas that were created to calculate GFR might only pertain to certain populations that have chronic kidney disease or populations that are slightly older. So we have to pay attention to the situation and the context of the patient, their creatinine, and their GFR. It kind of equates to the fact of looking at trends, not looking at one static number. You want to see overall how a patient has been doing. I did not mention BUN. I think a lot of people look at BUN and creatinine together. Truth is, I mostly stopped paying attention as closely to BUN the way that I pay attention to creatinine and GFR. And the reason why is because your BUN can fluctuate. Usually BUN just kind of signifies more about like someone's fluid status. Are they dehydrated? And we'll look at ratios of BUN to creatinine. But if someone's creatinine's up, usually their BUN is up. So those two kind of go hand in hand. Urinalysis is the last lab that we're going to cover. So patients will get blood, and then they should be giving urine tests whenever you're monitoring kidney function. And so a urinalysis or a UA has different things that we look at. So one thing I'm going to look at is the color. A lot of patients will come up to me and say, hey, doc, my urine was really dark this morning. And I'm like, okay. And they're like, but then it lightened up throughout the day. I said, yeah, that's normal, because as you're drinking throughout the day, your urine should be getting more pale. It should be either going to pale yellow or clear. But then when you sleep, you're not drinking. And so what happens is your urine gets concentrated. So you don't get rid of as much water the first thing in the morning, because you don't want to dehydrate your body. Your body wants to hang on to that water, but it gets rid of the toxins and stuff that it needs to get rid of. And so that's why it might be darker first void in the morning versus later on throughout the day. Clarity. That's another thing that we're going to look at with urine. We want your urine to be clear. We don't want it to be cloudy. You want to make sure that it's clear. One thing that's not looked at in the urinalysis, but patients will notice, are bubbles. Are you having a lot of bubbles that stick around? Do they look like a soapy film or an oily film on the water? Or are they bubbles that are there because the stream of urine is so strong and then they dissipate relatively fast? That's something to pay attention to. If you're noticing you're having a lot of bubbles and they're not disappearing and they might have a little rainbow film almost looking like soap or oil in the water, you should let your doctor know. Specific gravity is reported on the urinalysis, and this helps us to know if your urine is concentrated or dilute. So if it's dilute, your specific gravity is going to be lower, like 1.008, 1.006, something like that. If your urine is concentrated, which would be like first thing in the morning, your specific gravity is going to be higher, 1.012, 1.022, something like that. Protein, blood, and glucose. I want all of those to be negative in your urine. That's what I'm looking for. Don't want to see that you're spilling a lot of protein. I don't want to see that you're spilling glucose. But again, a urinalysis is not the end-all be-all. If I think that there's stuff going on as far as protein, I go more specific and I get a ratio, which we're going to talk about next. White blood cells and red blood cells are also reported on the urinalysis, and I'd also like for those to be negative. If you're having blood and red blood cells in your urine, one of the first things to do would be to make sure that we have an ultrasound of your kidneys to make sure that there's no fluid-filled sacs called cysts on the kidneys. If there are cysts, that might be the reason for the blood, but you probably need to see a urologist. If there are no cysts and still having blood and RBCs in the urine, then I would still send you to someone called a urologist, which is essentially like a surgical counterpart to the nephrologist, to make sure that there's no anatomical reason for you having blood in the urine. If you have white blood cells in your urine, it could possibly signify an infection, but it doesn't always. So lastly, the urine ratios. You have urine protein to creatinine ratio, which tells us how much protein is being lost through your kidneys. And so the normal range is going to be anywhere less than 150 to 200 milligrams per day. There's also the urine albumin creatinine ratio. So albumin is a specific type of protein that we're going to look at, which is also, the ratio will help tell us, could someone be actually having some diabetic kidney disease even though their creatinine hasn't changed? So creatinine might be one of the last things to change with diabetic kidney disease, and what we see first is the spilling of albumin and protein into the urine. And so a normal range of urine albumin to creatinine should be less than 30 milligrams per day. And that's it. Questions?
So thank you so much, Divya. There are a couple of questions that came in.
Okay.
The first one is, after transplant, how many times do you have to have blood tests done?
How many times do you have to have what?
Have blood tests done. So how often do you have to have your blood drawn, I guess?
It really depends on the institution. So it depends how well you're doing. So after a transplant, usually I'm seeing my patients about twice a week in the very beginning, sometimes 3 times a week. And each time they're going to get blood tests, and it's going to be multiple tubes of blood each time, because that CBC goes in a different tube than the chemistry, and then there might be other tubes looking at other things, including medication levels or maybe liver enzymes or viruses. So there's a lot of blood that gets drawn, but I would say typically for my patients, it's about two tubes, or not two tubes, two blood draws a week, at least for the first month to 2 months. And then it decreases from there to maybe one blood draw a week, then to one draw every 2 weeks. By the end of a year, I'm usually just getting blood tests about once every 3 to 4 months, sometimes every 6 months if the patient's very stable.
Thank you. And then also as a transplant recipient, when I'm looking at my labs, what numbers should I pay the most attention to or be the most aware of?
Like I think your creatinine is usually what patients are looking at. Again, I wouldn't necessarily pay attention to the GFR without talking to your doctor first, because if you have a transplant and your creatinine 0.9, it still might say the GFR is like 60 or something, and I wouldn't necessarily pay attention to that. Let your doctor kind of look at that. But the creatinine, and again, looking at that overall trend. So when my nurses are coming to tell me about someone's labs, they're usually presenting me with the current one, but then they say, by the way, their creatinine was this last time and it was this last time. So those are important. And then if you're a transplant patient, you should know your anti-rejection drug levels. So if you're on tacrolimus, you want to know what your drug level is there and what your goal is. You should always ask your doctor, like, hey, what's my goal? What am I trying to keep my tacrolimus dose at? Because we dose your anti-rejection medications based on how much drug is in the blood when we check it.
So I think this next question is a little bit controversial, but it is it true that there is a difference in GFR for African Americans than others? And if so, why?
So it's because when they came up with the formulas, traditionally, actually, African Americans have a higher muscle mass compared to non-African Americans. And so that's why GFR will usually be reported higher. So if you said a creatinine of 1, and let's say we said that creatinine of 1 is a GFR of 100, let's say it's 100 in me, it might be closer to like 110, 120 in an African American.
Thank you. So it sounds like from your presentation that medications can affect your lab results.
Mm-hmm.
And when taking a new medication, should there be any preparation for a change in lab results, or can there be anything that we can do to help prepare ourselves for these changes?
So I think the first thing is to, ask your doctor, like, is this medication going to interact with my current medications? What are the side effects? I know, like I said, like antacids, specifically like Prilosec or omeprazole, that's pretty common that patients take, and they might not know that it might decrease their magnesium levels and stuff. And so if we suspect it or we think it's going to happen, we have patients increasing like foods in their diet that might help with their magnesium. But I would say talk to your provider as to what to expect, like which way certain labs might go. Will this worsen this? What are the side effects? They should be telling you about those when they prescribe them.
That's great. And just waiting, I think we may have one more question because I did see a raised hand. So I'm just waiting for
Okay.
it to come in. While we're waiting, do you have any final words or advice? We'll give it another minute or so.
No, it's just about staying healthy, washing your hands.
Wearing your
um,
right.
and I think just good diet, exercise, and I mean, honestly, I'm hoping this is beneficial. I think the more informed you are about what your lab values are, what your kidney function is, these types of things, then the better you can take care of yourself and your health.
That's great. And the question that just came in is, should you stop taking a diuretic before a blood lab?
No, not
Okay.
unless your doctor told you to.
Okay. Thank you.
Yeah.
And I think those are all of our questions today. So thank you so much for joining us, and we really appreciate your presentation. And have a great afternoon, everyone.
All right. Enjoy the beautiful weather, everybody. Thank you.
Bye.
Bye-bye.